Thanks, Ian, and thanks, Jackie, for allowing me to present today on nutrition and hip fracture care. I think at the launch today, Debbie mentioned about the patient that had been fasted on again, off again for about 48 hours, and I think that's a common scenario that we see in the management of our patients. So I'm from the Metro North Hospital Health Service in Brisbane, and we run an orthogeriatric unit, and I'd like to acknowledge our senior dietitian who's done a PhD in nutrition and hip fracture care and is internationally recognised, and that's Jack Bell. So I'd like you to introduce Annie. Annie was our first patient in the hip fracture unit. Now, she's not our typical patient. She's actually a centenarian. She mobilised 2 days post, got to surgery within, I think, 6 hours because she was the first patient, so there was no delay in surgery. She mobilised in 48 hours, and this is her day 3 post-op. And what I'd like you to recognise is the steak and 3 veg and the pot roast that she's got contemplating. Now, as Jack mentions to me earlier, I said, well, she actually doesn't fit the typical patient who's malnourished. But as you know, a lot of our patients have problems with malnutrition. And the problem with malnutrition is that it's often underestimated, not just by clinicians, but loved ones, healthcare workers. Often, and the reason because it's often underdiagnosed or misdiagnosed, which I will talk about some of the screening tools. It has been undervalued in the past, but that will obviously change as we change practice. It's often been under the radar, both of not only on a local level, but also in health administration, but also national policy guidelines. And hence, it's often undertreated. And why is this so? I suspect it's because of the lack of evidence base consistently over a period of time. And so Jack often comes to me with this question, and I have to think about this, but this is the question he asked me. He says, oh, can I please tube feed her? I'm not pretty, but he does say pretty please. And often that has a lot of implications in terms of care needs, sort of special care needs. So we formed a research group that looked into these particular problems in hip fracture care. And so this is essentially an action or pragmatic research tools, in that we looked at, the problem at hand, the lack of nutrition in these patients, and then how we might observe, what we might do. We reflect, act and evaluate to obviously try and drive change. Now, the current problem with malnutrition is that it's a strong independent predictor of 12-month mortality, with the odds ratio of about 2.4. And it is associated with discharge destination. Often these patients need protracted periods of rehabilitation or slow-stream rehabilitation. Often needing changes in terms of, need for residential care. They are slower in terms of time to mobilise post-surgery, and they also increase risk of delirium. But it's also a comorbidity for the health administrators. It's a comorbidity with the largest increase in hospitalisation costs, both mainly of inpatient care, but also changes in outpatient care. But it's also most likely an increased length of stay. Now, why has malnutrition been underdiagnosed or misdiagnosed? Well, the screening tools to date, the time, the BMI and the albumin have been notoriously underreported, especially in frail older patients. And this has led to underdiagnosis of malnutrition and, for the bean counters, the loss of case mix funding. To date, the ICD-10, which has been Australian modified version coding for malnutrition, has the highest concurrent and predictive validity for the tool. Now, what's the ICD-10-AM? I mean, you don't need to go through this in detail, but essentially it's a combination between the subjective global assessment, and that looks at age, weight loss, subcutaneous tissue stores, etc., and reduction in BMI. So if the BMI is less than 18.5. But also in terms of between severe, moderate and mild is a reduction of weight loss of more than 10%, between 5 and 9%, and less than 5%. But that's over a period of time. It's unintentional weight loss in the patient. Now, why has malnutrition been under the radar? Well, first of all, at the guideline stages, initially with the UK NICE criteria, there has been a lack of recognition of malnutrition, but increasing enough, for instance, with the American Association of Orthopaedic Surgery, the Scottish Intercollegiate Guidelines, the Australian New Zealand Hip Fracture Registry, and the guidelines of hip fracture care done by in Cameron, has shown that malnutrition certainly is now getting to the forefront stages of as a significant need for care in this area. One of the other studies that we did was looking at what are the outlines or the feelings of patients and carers in this situation, healthcare workers, and these are some of the quotes when we gauge the population of people in this care. So I'd just like to take home a couple of messages. First of all, it's a culture. Hospital-wide, it's a task-orientated, and nutrition is one of those things down at the bottom. And this was from a assistant nurse. We're forgetting the basics. It's all about the bling kind of things. So presumably that means in every sort of high-tech gadgetry, etc. And this last point was, we do much else to patients in terms of sticking things in all parts, body and orifices. And at times, really interesting, that's the last thing that we'll think, oh, I didn't think we didn't think of that, so in terms of nutrition. So we did an audit in terms of the nutrition requirements of patients being admitted to the unit. And the first figure shows us the total 24-hour total energy intake for randomly selected patients with mean daily energy intake of 51.8 kilojoules per kilogram per day. Now, that is at this line here. So these are all the patients admitted with hip fracture. Now, the actual daily caloric requirements are between 125 and 140 kilojoules per kilogram per day. And only 2 of approximately 70 patients that were admitted in this study actually met these requirements. Now, that didn't mean that all those other patients were malnourished, because they didn't meet the previous ICD-10-AM guidelines. But what the prevalence on admission was approximately 52%. So 52% of patients admitted into the hip fracture unit were malnourished. And then during this stay, so whilst they were in the unit, either pre, post-op, or peri-op and post-operatively, another further 11% developed criteria for malnutrition due to weight loss, etc. So what do we do about this? Because we've identified the problem, and it's a difficult problem to fix overnight. But what we did was identify, develop, and implement a pragmatic action plan, short of tube feeding at this stage. So what we looked at was looking at using the multidisciplinary team. I mean, we're all in hip fracture care, and we all use the multidisciplinary team. We all looked at trying to have a proactive nutrition assessment and intervention for all patients, not just the ones who were classed as severely malnourished. Using the concept of medicalisation of nutrition, getting the registrars, admitting doctors, the junior staff to use the medical chart to chart nutritional supplementations, and also have a top-down approach or a collegiate approach between the geriatrician, even the surgeons, the anaesthetists, as well as the allied health and nursing staff, to elevate nutritional supplementation as an important part of the rehabilitation process. We coordinated a multidisciplinary approach and delegation of care, and we're looking at trying to enhance the food services systems. Often patients get menus for 2-3 days in advance. They still might be on a modified diet. I think it's more timely menus. I think it's nothing worse for some of our patients than having to have a texture-modified diet, which is not appetising in the period of time when food is one of the last things on their mind. But also improving the knowledge and awareness, not only of the treating team, but also of staff and carers. The last thing we did was did a study looking at between the standard care, which is dietitians looking at patients and following them up, and then transferring that to a multidisciplinary team approach. And what we did find that by doing this, their nutritional requirements increased from the 50 kilojoules per kilogram per day to approximately 100 kilojoules per kilogram per day. And this, substantially and significantly reduced nutritional barriers, doubled energy and protein intakes when patients required this the most, tripled return home to discharge rates, and quadrupled the reduction in patient nutritional deterioration. Now, whilst that helped a significant majority of patients, there still were, about 20% of patients, 20-25% of patients that were still not requiring nutritional requirements. So where do the challenges from here? Jack's nasogastric tube, which is one of his pet loves, I think. The question is, should we be enterally feeding these patients that aren't requiring the requirements, aren't making these requirements, despite all these other measures? And that has its own implications due to the comorbidity and the complexity of these patients, high degree of cognitive issues, which we know of. And should there be a consensus-based nutritional guidelines for these patients? And we've started by doing that by sending a Delphi survey through to ANZ and HFR members, which we will be looking at these issues. So the summary is, malnutrition in hip fracture patients is often underdiagnosed and misdiagnosed. It's an independent predictor of mortality, despite all the multiple morbidities that our patients have. It's a comorbidity associated with significant hospital cost, but also diagnosing this can also increase hospital case mix funding for patients. The improved value of adequate nutrition. The concept of malnutrition is part of the clinical frailty scale. Should that be considered for admission for all patients with hip fracture? It's an essential part of multidisciplinary care for hip fracture patients, and it should be everyone's business. So I'd like to acknowledge Jack, but also the multidisciplinary team from the hip fracture unit, and this is through all units, I think, involved in hip fracture care, that it's not just the geriatrician, the orthopaedic surgeon, but it's everyone involved in this care. It's often the special assistant nurses who are with these patients day in, day out, looking at their feeding habits that actually do improve the circumstances. So thank you.